There is a really specific phrase that drives me absolutely up the wall.
Let me guess.
Yeah,
They took the easy way out.
that is the one. I see it in comment sections all the time. I hear it at dinner parties, usually whispered, when someone leaves the room. And it's always about weight loss surgery.
Right.
It's this pervasive, lingering idea that getting a gastric bypass is somehow, I don't know, cheating. Like you just sign a permission slip, take a nap, and wake up thin without having to do any actual work.
Yeah, which is just wild if you actually understand the procedure.
Exactly. Because we have a massive stack of medical literature, patient protocols, and surgical reviews in front of us today. And the reality is, well, it is anything but easy.
It's objectively the hard way out. I mean, if
Mm.
you actually look at the physiology, calling the Roux-en-Y gastric bypass easy is like saying running a marathon is easy because you bought expensive shoes.
Mm.
We aren't talking about a tummy tuck here. We're talking about a total metabolic reconstruction.
Remodeling the house while you're still living in it.
Exactly. And not just painting the walls. We are tearing out the plumbing and rewiring the electrical system while the power is still on.
So that is our mission for this deep dive. We are going to completely dismantle that easy way out myth for you. We're going to walk you through the entire timeline of a gastric bypass patient, from the gauntlet of preparation to the operating table, and then the lifelong reality of living with a completely rerouted digestive system.
And I think the best place to start is with that word you just used, metabolic.
Mm,
Because that is the main disconnect for most people.
right.
Most people think this is just a plumbing job, making the stomach smaller so food literally doesn't fit. And sure, that's part of it.
Right.
But the source material heavily emphasizes that the Roux-en-Y is a major metabolic procedure.
Okay, so let's define our terms for the listeners. We are focusing specifically on the Roux-en-Y. It sounds like a fancy French sauce, but it's actually the gold standard for bariatric surgery. What is physically happening to the body here?
So imagine your digestive system is a factory line. In a normal body, food goes into the stomach, gets broken down by acid and churning, moves to the small intestine, and every inch of that intestine is designed to suck up calories and nutrients. The Roux-en-Y changes the factory floor plan in two very distinct ways. First, there is restriction.
This is the part everyone knows about, the egg.
Yes, the egg. The surgeon uses a stapling device to partition off a tiny, tiny pouch at the very top of the stomach. And when we say tiny, the literature compares it to the size of an egg or a walnut. That is your new stomach.
Wow.
Yeah, holds maybe an ounce of food.
Which is just a massive shift from a typical stomach, which can, expand to hold a quart or more of food and liquid.
Exactly. So physically, you just cannot overeat without immediate, incredibly painful consequences.
Yeah.
But the second mechanism is the one that really drives the long-term results, and that's malabsorption.
This is the rerouting part, right?
Correct. The surgeon takes the small intestine, cuts it, and brings the lower section up to connect directly to that egg-sized pouch. This forms a Y shape, hence the name Roux-en-Y.
So you are bypassing the main stomach and the first section of the small intestine entirely.
Right. And that first section of the intestine, the duodenum, that is the prime real estate for absorbing calories. By skipping it, your body literally cannot absorb everything you eat. You are forcibly reducing the caloric impact of every single bite.
But here is where the metabolic part really comes in, according to the data. It's not just about mechanics. When you bypass that specific part of the gut, you are triggering a massive hormonal shift.
It's profound. I mean, the gut is basically a second brain. When you reroute the food so it hits the lower intestine sooner, you alter the secretion of hormones like ghrelin, which is the hunger hormone, and GLP-1, which controls your insulin response.
And the sources say this happens almost instantly.
Almost instantly. Patients often wake up from surgery, and their type 2 diabetes is in remission before they've lost a single pound.
That is insane to me.
It's incredible. Their blood sugar normalizes because the hormonal signaling has been entirely rebooted by the rerouting.
That just blows my mind. It's not the weight loss curing the diabetes, it's the surgery changing the chemical signals in the body.
Yeah, it's like updating the software and the hardware simultaneously. But, and this is a huge but, you don't just walk into a clinic and get this software update. You really have to earn it.
Yeah, let's talk about that. Let's talk about the gauntlet. I was reading through the eligibility requirements in our medical overview, and honestly, getting into an Ivy League school seems easier than getting approved for this surgery in some cases.
Oh, it's a total endurance test. And it has to be. The medical criteria are just the baseline. Generally, you need a BMI over 40. Or if you have obesity-related conditions like the type 2 diabetes, sleep apnea, or high blood pressure we mentioned, a BMI over 35.
But that just gets your foot in the door. Then comes the actual vetting.
The vetting is intense. We see requirements for comprehensive psychological evaluations to ensure you're mentally ready for such a drastic change. You have to undergo nutrition counseling. And here's a big one that trips a lot of people up. Insurance often mandates a supervised diet program for 3 to 6 months before they will even authorize the surgery.
This part always confuses people. You have to prove you can diet.
In order to get a surgery to help you lose weight.
Yeah. It feels completely counterintuitive. If they could lose the weight on a diet, they wouldn't need the major surgery.
It does sound backwards. But the clinical argument there is all about compliance. Post-op life requires incredibly rigid adherence to rules. If you can't track your food, show up to appointments, and follow a plan now, the surgery won't save you. In fact, it might actually hurt you.
They need to know you are all in.
Precisely. They need to see that you are a reliable partner in your own medical care.
Speaking of being all in, there is one specific hurdle right before the surgery that stood out to me as particularly brutal: the pre-op diet. Or, as the patient forums affectionately call it, the liver shrinking diet.
Yes. The 2 weeks of absolute misery.
It's essentially a liquid-only, high-protein diet for 7 to 14 days right before the operation. And the clinical notes say this isn't really about weight loss at all. It's a surgical safety protocol. Why does the liver matter so much for a stomach surgery?
It's purely anatomical. Most people carrying significant excess weight have what's called hepatic steatosis, a fatty liver. Physiologically, the liver sits right on top of the stomach. For the surgeon to get to the stomach to do the laparoscopic work, they had to physically lift the liver up and out of the way.
And if the liver is fatty,
it's heavy, it's stiff, it's enlarged. If a surgeon tries to leverage a heavy fatty liver with laparoscopic tools, it can crack.
Oh, wow.
Yeah, it can bleed. It obscures the view. It makes the entire surgery significantly more dangerous.
So this intense crash diet is just to deplete the glycogen in the liver.
Exactly that. When you cut carbs and calories drastically, the liver burns through its glycogen stores and loses a ton of water. It physically shrinks. It becomes floppy and much lighter. It turns a high-risk surgical maneuver into a routine one.
But for the patient, it means going cold turkey on food for 2 weeks right before the most stressful event of their entire life.
It's the first real test of willpower.
So let's say you survive the liquid diet, you pass the psych eval, it's game day. Take us into the operating room. What does this actually look like?
Well, almost all of these are done laparoscopically now. That means small incisions, cameras, and long instruments, rather than cutting the patient wide open. You're under general anesthesia, and the whole thing takes about 2 to 4 hours depending on the complexity.
We touched on the anatomy earlier, creating the egg pouch and the Y connection, but I want to clarify something about the old stomach. The sources call it the remnant stomach.
Right.
I think a lot of people assume the rest of the stomach is removed, like taken out of the body entirely, like an appendix.
That is a very, very common misconception. The rest of your stomach stays right there inside you. It's just disconnected from the food pipeline. It's stapled shut at the top. No food will ever go into it again. But it's still a living organ. It has blood supply. It's still in there doing its biological thing.
We're definitely going to circle back to that later because that has some weird philosophical implications. But let's fast forward to waking up. You're in recovery. You've just had your insides completely rearranged. What is the immediate sensation for the patient?
Pain, obviously.
Yeah.
But specifically, gas pain.
Gas pain.
Yeah. They pump the abdomen full of carbon dioxide during surgery to create a dome to give themselves space to work. That gas gets trapped inside. It settles in the shoulders and the chest. And the only way to get it out is to walk.
Which brings us to the blood clot protocol.
It's non-negotiable. You are extremely high risk for deep vein thrombosis or DVT after this. So mere hours after a major abdominal surgery, the nurses are dragging you out of bed to walk the hospital hallways. You want to sleep, you're in agony, but you have to move.
Okay, so you survived the surgery. You go home after a few days. Now begins the recovery phase, specifically those first 6 weeks. And looking at the diet progression in the source material, this is where the easy way out narrative just completely dies.
No, absolutely. It's a full reset of how you interact with sustenance. For the first 2 weeks, it is clear liquids and full liquids only. Broth, protein shakes, sugar-free fluids, no solids, none.
And the main risk here isn't starvation, surprisingly. It's dehydration.
That's the #1 cause of hospital readmission. Think about it. Your stomach is the size of a walnut.
Yeah.
You literally cannot chug a glass of water. You can't gulp. If you do, it'll come right back up because there is simply nowhere for it to go.
So you just have to sip.
You have to sip, sip, sip all day long. It becomes a full-time job. If you fall behind on your fluid goals by noon, you physically cannot catch up before bed because of the volume restriction. That dynamic lands a lot of people right back in the hospital on an IV drip.
Then eventually you graduate to pureed foods, mashed potatoes, yogurt.
Pureed lean meats, soft scrambled eggs. But the fundamental rules of eating have changed forever. You are now eating portions the size of 2 to 4 tablespoons.
2 tablespoons. I mean, that is a single bite for most people.
It's a bite or two. And you have to chew it thoroughly, basically to the consistency of applesauce before you even attempt to swallow.
Right.
If you don't, it can get stuck.
The foamies, I saw that term in the patient protocols and forums. It sounds horrific.
It's very unpleasant. If food gets stuck in the stoma, which is the tiny new opening to the intestine, the esophagus produces excess mucus to try to lubricate it and dislodge it. So you end up regurgitating this thick, gross foam. It happens if you eat too fast, if you don't chew enough, or even if you just eat meat that is slightly too dry.
There's also this other phenomenon mentioned in the medical overview called dumping syndrome.
Oh, this is the big one. And honestly, from a biological standpoint, it's a fascinating feedback loop.
Honestly, it sounds like a punishment.
Well, it effectively is a punishment. Remember, we bypass the pyloric valve. That's the muscle at the bottom of the normal stomach that regulates how fast food enters the intestine. Without that valve, if you eat refined sugar or something really fatty, it just dumps straight into the small intestine way too fast.
And the intestine just panics.
It completely panics. It draws massive amounts of fluid from your blood supply directly into the gut to try and dilute the sugar. This causes your blood volume to drop suddenly. Your heart rate spikes. You get dizzy, profusely sweaty, nauseous. You might have instant severe diarrhea.
It sounds like a severe panic attack combined with the stomach flu.
It feels terrible. Patients describe needing to just lie down on a cold tile floor for an hour until it finally passes. But in a way, it acts as a behavior modification tool. It is a harsh physical deterrent against eating sugary, high-fat foods.
Yeah.
You learn very quickly to avoid that piece of cake.
So you get through those brutal first 6 weeks, you're healing. Now we enter what the literature calls the honeymoon phase. This is roughly 2 to 12 months post-op.
This is when the magic happens, so to speak. The weight starts falling off. We're talking 1 to 3 pounds a week consistently. The joint inflammation drops. The energy comes back. For a lot of people, this is the first time in their entire lives they feel in control of their body.
But checking the sources, it's not all sunshine and rainbows. The body is still under massive systemic stress. One side effect that seemed really traumatic for people during this phase was the hair loss.
Telogen effluvium. It's very common. The body senses starvation due to the rapid weight loss and the trauma of surgery, so it goes into conservation mode. It conserves energy by shutting down non-essential functions. Making hair is considered non-essential.
So 3 months after surgery, you're losing weight, you're finally feeling good, and suddenly your hair just falls out.
Clumps of it in the shower drain. It creates a massive amount of anxiety. It's temporary. It does grow back once the weight loss stabilizes, but mentally it's a really hard blow right when you're starting to feel better about your appearance.
And while we're on the physical changes, we have to talk about the vitamins. This isn't just taking a Flintstone vitamin and you're good for the day. The medical literature explicitly calls this a survival requirement.
This is absolutely critical. Remember the malabsorption component we talked about. You aren't just absorbing fewer calories. You are absorbing far fewer nutrients, specifically iron, vitamin B12, calcium, and vitamin D.
So what does the daily regimen actually look like for you?
It's daily for the rest of your life. Bariatric-specific multivitamins with extremely high doses, usually taken twice a day, plus additional calcium citrate, B12, and iron spaced out so they don't block each other's absorption.
And what happens if you just don't do it? So you feel fine a year out and you just stop taking them because they're expensive or annoying?
The consequences are severe, and sometimes they are irreversible. We aren't just talking about feeling a bit fatigued. We are talking about severe, life-threatening anemia. We see severe osteoporosis and bone fractures in 40-year-olds because the body is literally leaching calcium from their own bones just to keep the heart beating.
And the nerve damage. I saw that in the notes.
That's the B12 deficiency. If your B12 gets too low, you can develop peripheral neuropathy, which is tingling or numbness in the hands and feet. If you let it go on too long without treatment, that nerve damage becomes permanent. You cannot fix it.
That is a very heavy trade-off. You get your metabolic health back, but you are tethered to this strict pill regimen forever.
That's the reality. And there is a significant emotional toll, too, which the sources highlight. They call it identity adjustment.
Yeah, let's unpack that. Because you'd naturally think losing 100 pounds would just instantly make you happy.
It's a lot more complicated than that. Imagine being treated one way by society your entire life because of your size, maybe ignored, maybe disrespected, invisible. Then suddenly, within a single year, that entirely changes. People hold doors for you. Clerks make eye contact and smile.
And that can feel pretty jarring.
It often breeds a lot of anger, actually. Patients frequently ask, why wasn't I worthy of this basic human kindness 80 pounds ago? It can also severely disrupt relationships. The data shows divorce rates actually spike after bariatric surgery.
Really? A spike in divorce?
Yeah. Sometimes the partner was the feeder, or they were the secure one in the dynamic. Suddenly, the patient is confident, getting outside attention, and wanting to be highly active. It completely shifts the power dynamic in the home. It takes a massive amount of communication to navigate that shift.
Let's look at the long game then. We are talking a year or more out from surgery. What are the general outcomes?
Generally, they're excellent. The typical result is a 60 to 80% loss of excess body weight. Most comorbidities like sleep apnea and hypertension completely resolve.
But the lifestyle changes are permanent. There was one specific rule that surprised me in the long-term management protocols. No NSAIDs.
Right. No ibuprofen, no Advil, no Motrin, no Alev.
Ever.
Generally speaking, never again.
Why? What do NSAIDs do to the bypass?
Ulcers. NSAIDs work by blocking certain pain enzymes, but they also reduce the protective mucus lining of the stomach. The new bariatric pouch is incredibly sensitive. If you get what's called a marginal ulcer at that surgical connection point, it is incredibly painful, very hard to treat, and it can actually perforate.
So if you have a headache,
It's Tylenol.
if you have a bad knee,
Tylenol, that is a significant quality of life change that I really don't think people realize until they're living it every day.
and then there's the elephant in the room that the data covers, weight regain.
It happens. The surgery is a tool, not a cure. The biology always fights back. The pouch can physically stretch over time if you constantly overeat. But the much bigger culprit is what we call grazing.
Snacking all day.
It's the ultimate loophole in the surgery. The surgery restricts volume, right? But it doesn't restrict time. If you eat slider foods, crackers, chips, pretzels, they chew down to a wet paste and literally slide right through the pouch without ever triggering that full feeling.
Because they don't take up any physical space in the pouch.
Exactly. You can eat 2,000 calories of potato chips over the course of an afternoon and never once feel stuffed or sick. If you return to those old habits, the weight will absolutely come back.
Which goes right back to what we said at the start. It requires work.
Relentless work, and it requires lifelong vigilance regarding complications. There is a persistent risk of internal hernias, for example.
What is that exactly?
Because the intestines have been moved around and rerouted, there are new windows or empty spaces in the abdominal cavity. Loops of intestine can slip into those spaces, get tangled, and get stuck. This can happen 2 years later or 10 years later.
And that's a medical emergency.
A bowel obstruction is a life-threatening emergency. So if a gastric bypass patient has severe unexplained abdominal pain 5 years post-op, they cannot just take a Tums and go to sleep. They need a CT scan immediately.
So let's zoom out for a second. We've gone through the gauntlet of insurance vetting, the liquid liver shrinking diet, the surgery itself, the walking in agony, the sipping tiny cups of water, the dumping syndrome, the hair loss, the vitamins, and the lifelong dietary restrictions. When you look at all of this laid out, the idea that it's the easy way out just completely evaporates.
It really does. It's just a different set of hard choices. You are trading the health risks of severe obesity, which are immediate and life-threatening, for a brand new set of risks and rules that you have to manage forever. You gain metabolic control, but you lose the freedom to eat mindlessly.
And briefly, is it reversible if someone changes their mind?
Technically, yes. It can be reversed surgically, but in practice, it is considered strictly permanent. Reversal is high risk, technically very difficult, and rarely done unless there are severe life-threatening complications. You should definitely go into it assuming it is forever.
It's a one-way trip.
It really is.
As we wrap up this deep dive, is there one thought or image from the research that really stuck with you?
You know, it's something we touched on earlier, but I just can't stop thinking about the concept of the ghost stomach.
The remnant stomach, the part that gets bypassed.
Yes. Just think about it for a second. You have this major surgery, you lose the weight, you completely change your life. You look totally different in the mirror. But inside you, that original stomach is still right there. It's living its own life in the dark. It has blood flow. It produces hormones. It makes digestive enzymes. It's doing its biological job.
Even though it never touches a piece of food ever again.
Exactly. It serves as this permanent physical reminder that the surgery didn't actually remove the biology of obesity. It didn't cut out your history. It just rerouted it. The potential for the disease is still there, living in that bypassed organ. It really highlights that while the surgeon does the plumbing, the patient has to do the steering.
The biology is rerouted, but the driver is still you.
The mental and behavioral steering, that's the only thing keeping the car on the road for the rest of your life.
That is such a powerful place to leave it. To everyone listening, thank you for taking this deep dive with us into the mechanics of metabolic change. It's complicated, it's intense, and it is definitively not easy. Take care of yourselves, and we will catch you on the next one.
Keep exploring, everyone.